Good morning, good afternoon, good evening, everyone, and welcome to this echo session. Today's echo session, we are looking at evaluation, and we are recognizing that many countries are rolling out a monitoring system to track various results, especially in the implementation of viral load. However, from time to time, there is a need to evaluate a country's program to determine if it is meeting the set objective and if the desired outcome and impactful results are being achieved. So this session, we'll have an overview of evaluation guidance and tools by WHO, and then we'll have a practical consideration for country teams to plan and evaluate their country program that will be done by clear outcome. By the highlight, we have two presenters. We have Dr. Robert Luo. Dr. Robert Luo is a diagnostic consultant for WHO and a clinical pathologist with expertise in virology, microbiology, and global health. Previously, he has worked at Stanford University for US CDC and the diagnostic industry on HIV viral load testing and point of care and laboratory-based diagnostic program for infectious diseases. We're also joined by Dr. Joris Vandelanotte. Dr. Joris is a medical doctor who is a specialist in public health medicine with over 25 years experience in sub-Saharan Africa in the field of public health, health system strengthening, primary health care, monitoring and evaluation, and operational research. He is currently working as an independent consultant focusing on public health. For those who are joining us from French-speaking countries, or for those who would want to join to follow this session using French, please, at the bottom of your screen, choose French and you're able to follow the presentation on French. And just to remind you, in case you have questions during the presentation, write the question in the chat box, and then the presenters will pick them during the discussion session of this session. We'll first have the presentation, after which we'll go to the questions and attempt to answer as many questions as time will allow. The presentation will run, the session will run up to 5 o'clock East African time, so for the next 54 minutes. Without further ado, I would want to welcome Dr. Robert to start us off. Welcome, Dr. Robert.
Great, thank you very much, Michael, for the kind invitation, and good afternoon, everyone. Let me share my screen. So I'm so happy to speak today on monitoring and evaluation of HIV viral load programs. And I think all of you on this call today deserve a thanks for working on the scale up of HIV viral load in your countries, particularly through the COVID-19 pandemic and afterwards. Without HIV viral load programs, we wouldn't have anything to monitor or evaluate. So there's been such impressive work on the scale-up of viral load testing, and it's so nice to be able to speak about how to monitor and evaluate the progress of those programs. So in 2015, WHO published 10 global indicators for HIV monitoring and evaluation. I'll just highlight a couple of these indicators which are relevant to HIV viral load testing. The first is the first indicator. So first, of course, you need to know the number of people living with HIV. Then indicators 4 and 5 are knowing the number of people who have been diagnosed with HIV, who know their HIV status, and the number of people living with HIV who are receiving HIV care, including antiretroviral therapy. Indicator number 6 is the number of people who are on antiretroviral therapy. And then indicator number 8 is viral suppression. So the number and percentage of people who are receiving antiretroviral therapy with suppressed viral loads. And I think that's our goal here, is being able to identify people who are living with HIV, being able to provide them high quality HIV care, including antiretroviral therapy, and then being able to get as many people as possible virally suppressed. So in 2019, WHO updated its framework for monitoring and evaluation of HIV viral load programs. And I'll be presenting that framework to you on this call today. This is the viral load testing cascade. So we think about the HIV care cascade, but this cascade focuses on viral load testing in particular. So again, we start with the number of people living with HIV who are receiving antiretroviral therapy, because those are the people who will need to be monitored with a viral load test. Out of those people, we then have a number of people who are getting at least one annual viral load test, depending on where they are in the viral load algorithm. The next step of the cascade is the number of people living with HIV receiving antiretroviral therapy who have access to viral load testing. So they can either receive viral load testing through a venous blood draw, through point of care testing, through dry blood spots. Then you have the number of people living with HIV receiving antiretroviral therapy who actually receive a viral load test. Out of those people, we can look at the number of people living with HIV who have suppressed viral loads. And then finally, we can look at the number of people with suppressed viral loads who can then be referred to a less intensive model of care. So what are some key variables for laboratories to consider in order to be able to collect this sort of information? So we know that there are several forms that the laboratory has access to and the HIV program can use to collect information on how the viral load program is doing. This information not only helps for monitoring and evaluation, but it also is necessary for the program to keep track of the patients themselves. So the first example of a form that's used during the monitoring evaluation process is the specimen requisition form. This is something that's filled out typically at the clinic and then is sent to the lab to be able to identify the blood specimen or the dry blood spot specimen that's used for viral load testing. And it includes information such as the patient information number, where the specimen is being collected, demographics of the patient, such as their date of birth, their sex, what their antiretroviral therapy status is, the date and time the specimen was collected, and the type of specimen. And then there's a second form, the testing requisition form, which can be entered at the laboratory. For this, there's also demographic information. Here, we could also put the result of the viral load test, including which test was used, the specimen quality, just in case there were any issues with the specimen, how the specimen was received, for example, the date and time the specimen was received, when the specimen was tested, and when the result was actually reported. So we can look at core indicators along the cascade that programs can look at in order to evaluate how the program is doing. So for example, if we go back to the steps in the cascade of the viral load testing that I showed earlier, if we look at a key step such as ordering the viral load test, one core indicator that can be used for routine monitoring is looking at the percentage of sites within the program specimen transport network that are submitting samples for viral load testing. A second step would be how the viral load test sample is processed. A core indicator could be the number of viral load tests received by the laboratory from sites and the number of viral load tests run by the laboratory. The next step would be how many results are actually returned. So this could be evaluated and monitored by looking at the percentage of viral load tests that are actually returned to the sites within 1 month of the sample being taken. The next step would be looking at coverage, documentation, and the outcome of the viral load test result. Because of course we want these tests not only done, the results reported, but actual action taken because of the results. So for this, there are a series of indicators that can be looked at, such as the percent of people who are on antiretroviral therapy who have viral load results 12 months after initiating therapy, the percent of people who have viral loads under 1,000 copies per mil at 12 months, and so forth. We can also look at what percentage of people actually have an intervention on a viral load test result if the viral load is above 1,000 copies per mil. So here we would look at the percent of people receiving antiretroviral therapy with viral loads above 1,000 copies per mil, who then go on to receive enhanced adherence counseling. And then for those people with viral loads above 1,000 copies per mil, we can look at what percent have follow-up viral load tests ordered within 3 to 6 months after enhanced adherence counseling. And of those people who receive a follow-up viral load test, what percent of those then have a suppressed viral load under 1,000 copies per mil? For those people who still have a persistent viral load above 1,000 copies per mil, the algorithm indicates that a second-line antiretroviral therapy regimen should be used in these individuals. So for this, we would look at the percent of people who are actually switched to a second-line, or in some cases, a third-line antiretroviral therapy regimen. So this just shows the cascade again, but calls out the individuals who have viral loads above 1,000 copies per mil, realizing that essentially at any point along the algorithm, you can look at the program data to see how many individuals are being managed in the appropriate way according to the algorithm. So not only looking at the number of people with suppressed viral loads, but also making sure to follow the number of individuals with viral loads above 1,000 copies per mil who need a follow-up test. And the goal would be to get them under 1,000 copies per mil so they can resume routine viral load testing and resume routine care under their program. So when we look at how to evaluate service quality and viral load testing in a program, we can look at two different things. First, we can look at assessing compliance with national guidelines and viral load monitoring in your country. And this can be done at the site level, looking at the indicators that I spoke about with regards to viral load testing, follow-up, and referrals. The second thing we can look at is assessing compliance with national guidelines on managing treatment. Since of course we want to do viral load monitoring in order to make sure that people are on the optimal treatment regimens for them. So for this, we look at if treatments are being changed in a timely manner to second-line regimens or even third-line regimens when necessary in accordance with the guidelines in your country. And when we look at evaluations, there are two types of evaluations we look at. We'll hear more about this in the next presentation as well. But in the WHO framework, we also talk about you can do process evaluations where you evaluate how the process was going. So for example, you can look at were the target populations reached? Was the program implemented as planned? What were the kinds of problems that were encountered in delivering the program? For example, were there enough resources from the beginning to do the program? Was the program well managed or not? Were staff trained to the right level to be able to operate the program? And was there adequate support for the program? These sorts of evaluations help programs decide how to best make decisions, how to allocate resources, and overall, how to decide how to improve programs. Then we also have outcome evaluations, where we look at were the intended outcomes of the program achieved. Was the program more successful with certain groups of people than with others? What aspects of the program did participants find gave the greatest benefit? Did implementing the intervention result in changes in knowledge, attitudes, and skills? Did the program have any unintended effects on the target populations? And how has the intervention changed the quality of services? In a similar way to process evaluations, outcome evaluations also assist with decision-making in a program, decisions on how to allocate resources, how to improve programs, and how to determine whether or not the program has been effective. So this is an example of how data can be summarized from all of the indicators that I mentioned. So programs can identify core indicators for them on how they want to monitor their program. And here you can look at things such as, what the number and percentage of individuals who have viral loads above 1,000 copies per mil, how many received adherence counseling, how many received a follow-up viral load test, what percentage of those had follow-up viral loads above 1,000 copies per mil, and for those people with elevated viral loads, even on the follow-up viral load test, the number and percentage of those who had their antiretroviral therapy regimen switched. And then in the latest update to the framework for HIV monitoring and evaluation that's available on the WHO website, we were also able to include examples. For example, at the time from the program in Uganda, they kindly provided examples that we were able to share on our website. So for example, this is a sample patient register that could be used where you have many of the variables that I spoke about earlier. This not only includes the laboratory information, but includes the treatment information for a patient. And then you have a sample laboratory reporting form. So again, this has a summary of the patient information, such as their ID number, some of the demographics of the patient, summary of their treatment information, and their viral load results. So you can see at the bottom of the form, there's a place to actually report the result of the viral load. And then the form reminds sites on what the recommendations are. So if a patient has an unsuppressed viral load, these are the steps you should take: enhance adherence counseling, repeat the viral load, etc. And then this program had a separate register to follow up high viral load patients specifically, since these individuals need more intensive monitoring. So in this follow-up register, this was where you could record things such as their first viral load result, whether or not they received enhanced adherence counseling sessions, and so forth. So in summary, you can think about monitoring evaluation by coming up with a plan. In the next presentation, we'll go further in depth on this. But in our framework, we provide a matrix for evaluation planning. And you can follow these steps to be able to think about how to set up a monitoring evaluation program. So first, you think about what questions you would like to answer through your evaluation. What do we need to know or evaluate about the program? Then you think about what type of evaluation you would like to do. So would you like to do a process evaluation, looking at how the program is operating? Would you like to do an outcome evaluation to see, is the program achieving its intended outcomes? Or would you like to do both? Then you would think about what variables and indicators that would be most helpful to answer your evaluation question. You would then look at data sources that could be available. So these are the patient registers, the laboratory reporting forms that we saw examples of. You can think about data collection method. So how will the data actually be collected from these data sources? Will you do any additional sources of data collection, such as interviews? What kinds of document reviews or reviews of program data will happen? And then finally, you can plan what the dissemination and use of these findings will be. So it can be an intensive amount of effort to go through a monitoring evaluation, but because of that effort, it's important to know how you're going to share those findings, how will stakeholders use these findings to improve programs, and whether or not evaluation findings would be publicly available, since oftentimes it's so helpful for programs to share the results of their findings. So thank you for your time today, and I'll be happy to answer questions and participate in the discussions after the presentations are over. Thank you.
Thank you, Robert, for the presentation. I'm going to welcome Joris, then we'll take the questions together. Welcome, Joris.
Okay, thank you. Good morning, good afternoon, good evening, everybody. Let me try and share my screen. Okay, is that clear for everybody? Is the presentation visible?
Yes, it is.
Wonderful, thanks. Okay, so just to introduce Clear Outcomes quickly, we're a group of evaluators with expertise in global health. We're actually currently doing the midterm evaluation of the LabCoP project. It's not evaluation of the viral load program, but of the actual learning network. You actually may have received an invitation to participate in a survey or in a key informant interview, and we would appreciate your thoughts on the project, definitely. So please fill in the survey or book an appointment if you have been invited. So the brief for the presentation today was to provide some practical guidance on how to approach the evaluation of HIV viral load programs. It's not an easy task. You have different programs, different evaluation needs, and also evaluation is a broad topic. So here's what I can offer. I can provide a brief overview of what our evaluations are, how they differ from monitoring, and provide some practical tools and guidance on how to manage an evaluation, and then give you a few practical tips and tricks. But first, I want to start with a quick poll with 2 questions. Anafi or Michael, can you pull up the poll, please? So the first question is, and you can answer now, have you heard of better evaluation? And the second one is, have you ever used the Better Evaluation website? Now I'll give you a bit of time to respond. Okay, I see that. Wonderful. Yeah, thanks for, you're still voting. Although it seems like, relatively few people have heard about Better Evaluation, and even less people have actually used the website. Okay, sorry. Maybe I can, okay, I can remove this. If I can achieve one thing, and if you take one message away from this presentation, that is that you might want to have a look at Better Evaluation, their website. It's an evaluation resource that I use on a regular basis. It's both a teaching aid, you can start learning straight away. It's a very comprehensive resource of different evaluation methodologies and approaches, but it also has some systematic tools and approaches towards doing an evaluation that may help you manage an evaluation as a person who's not necessarily an evaluator. So let's start just by defining what's an evaluation. It's basically taking a step back on the work that's been done on your project, on your activities. Better Evaluation talks about a systematic process, which is important. You need to have a system. Robert mentioned that these are often expensive, so you want to do it correctly with the right steps and the right approach. And then there's another definition here of the OECD, which focuses on relevance, efficiency, effectiveness, impact, and sustainability. But above all, evaluation is action-oriented. It seeks to answer a range of questions, but it's an important concept. It should lead to action, inform key stakeholders, donors, implementers, recipients. Should we do a course correction? Are we achieving our objectives? Is it done at a reasonable cost? Is it sustainable? Should we continue with the activity or not, or with the project? So it kind of leads to action and change in a way. Robert already mentioned a bit on the types of evaluation. So you have different ones, process evaluation, outcome, and impact. I'll show you a slide just now, kind of framing it a bit within a results framework. You kind of know this already, I think. Inputs, activities, output, outcome, and impact. And so process evaluation would look at the processes. outcome and impact would more focus on outcomes, kind of the results and then impact. They even may look at the longer term outcomes after a project's finished or an activity is finished. 5 years later, what's the eventual final impact of that activity? You can also look at the timing, so baseline, midterm, or endline evaluations. Then you have the purpose. It could either be formative to really make improvements on your project, or it can be summative, where you would look at informed decision-making about whether to start, continue, expand, or stop an intervention. I'll give you a comparison. If you think of a cook in a restaurant who's preparing his soup, and he tastes the soup, maybe he wants to add spices or salt, well, that's to improve his soup, isn't it? So that's a formative evaluation. Now, the client who sits in the restaurant, who eats the soup, well, that's a summative evaluation. Does he like it? Will he come back for more or not? And so that's kind of the difference between formative and summative. And then you can also have external evaluators. That would be a company likely outcomes doing an evaluation, or you could have an internal team doing an evaluation. Here I show a few differences between monitoring and evaluation. I think evaluation looks at the bigger picture. It's this idea of taking a step back and looking at, where are we now? Where do we want to go? Whilst monitoring looks at the day-to-day operational management issues, it looks at, internal program management, continuous improvements, whilst evaluation looks more at outcomes, impact, document successes and lessons learned, and share them as well. Now, sorry, I don't have any shares in battery evaluation, and it's a free resource, so, but it's really something that's very, very helpful, especially also for people who are not evaluators, because it gives such a systematic guidance. And so they use what they call a rainbow framework, where there are different steps of the evaluation. And for the purpose of this presentation, I will speak about the management of an evaluation. So there's 9 steps they propose. The first one would be on, deciding about how will you make decisions about the evaluation. The second one would look at the scope of the evaluation, think a bit about, the different types of evaluation, and what would you like the evaluation to achieve? What decisions will you base on the outcomes of the evaluation? The terms of reference is a very important document, especially if you commission an evaluation, so you would manage an external company doing an evaluation. And battery evaluation has a very nice tool to help you develop a good terms of reference. It's called the terms of reference generator. It's completely free. You have to register to access the tool, but it gives you, a systematic approach towards developing the terms of reference. And of course, one of the key things is developing your evaluation questions, because they will be the basis of your methodology and of your data collection and analysis. The evaluation design methodology is then in the next step. Then you develop a work plan, you do your data collection and analysis, you develop your reports, and that would include a methodology, results, conclusions, recommendations. And then, as Robert already mentioned, disseminate the reports and use the evaluation. That should be both internally for your own organization or your project, but it should also be externally with, other countries. And I think a platform like LabCoP is really kind of well placed to, share lessons learned from evaluations of different activities. Okay, so they say in theory and practice are the same, but in practice they're not. So I'll give you a few practical tips that may be useful. The first one is don't reinvent the wheel. There's already, previous evaluation activities, reports, terms of reference in your field or in your area that you could use and get some inspiration to get going. Secondly is start early. So think about evaluation activities at the beginning of your project, make it part of your M&E plan. And even with external evaluation, have your evaluation partner on board at the start of the project. And another tip is that, we want to be comprehensive and, kind of have the best methodology, but often the budget is the limiting factor. So be realistic about what you want to do and kind of look at the budget as well in terms of, your methodology and your activities. And then, sorry to be a bit repetitive, but use the better evaluation resources because they're really going to help you forward, both in terms of having resources or new ideas for methodologies or approaches. So with outcome and impact evaluations, you want to think about causation. Did the activity, was it responsible? Can we attribute these changes to our project activities? And there, the gold standard is, of course, a randomized controlled trial, but that is rarely used in evaluations because evaluations kind of work in the real world, not in the scientific world. And so there's different approaches. You could check consistency with causal contribution. You could investigate possible alternative explanation for your changes. Were there other projects, other activities? Were there other, new developments that were responsible partly or fully for the changes that you see? You could use a counterfactual control group. As I mentioned, if it's randomized, it's the gold standard. It can also be non-randomized, adjacent communities, geographies. You could compare it to a general population. Before-after comparison, you have to be careful with that approach, and I'll show you a slide to kind of make you thinking a bit about using that approach. But often what evaluators would do is use a combination of different approaches that corroborate each other. Okay, so let's think about the before-after design. And before you all fall asleep, I'll have a few questions linked to a few polls as well. So imagine you kind of working in a laboratory and you start an intervention and activity to increase demand for viral load in the community. So you start a social media campaign in May and June 2020 for clients on art. And you measure the proportion of people on art who are due for a viral load test who actually receive a test. And so these are your results. So this is the period here, the brown, where you did the campaign. And these are the changes over time you measure for all year. So now my question is, do you think the intervention is responsible for these changes? And Michael or Anafi, can you pull up the poll? Do you think yes, no, or you're not sure? So are these interventions, are they responsible for these changes, yes or no? I'll give it another half a minute, 30 seconds for people to participate. Okay, so it seems like around half of the people think yes, 20% says no, and 30% is not sure. Actually, what we see here is that the change starts earlier in February. So there may be other reasons why there is an increase in viral load testing. It may be that there's more capacity in the laboratories to do tests or other reasons. So I would rather say no, but it's difficult to say. Okay, let's have a second one. Nafi, if you can repeat the same question. So this is the second graph. It's the same question. Do you think these interventions actually, were the cause of this increase here in September? It seems like more people are convinced here. Yeah, around 2/3 of the people participating say that yes, and it is possible. It's also possible that there's a bit of a delay, a lag between the campaign and the actual increase, which may be reasonable that people would come in a bit later, a few months later. So I would rather say tend to indeed yes. Let's have a third one. I'll look at this graph. It's the same kind of question. And again, here, think about, are these changes due to okay, get a similar result, 60%. It's actually a bit the same as this particular slide, just that there is more of a variation, in the data. So there's more of a variation. I think there's an overall trend here and there's a peak here. So you could attribute it. You could also say maybe there's another reason why September is such a high number. And okay, the last one, which is this one. And it's the same question. So here's the program running, and all of a sudden then yeah, so I think here's this is the clearest example, kind of the baseline is around 20%, and then from here onwards it starts and it actually continues. I think here, this first example, I doubt that there was a change. Here, the change may have occurred in these two instances because of the intervention, but it wasn't sustainable. And here you see actually a change that is, consistent with the time, but it's also kind of that's sustainable. Now, the interesting part is this. If you would compare a before-after and look at February 2020 and September 2020, then for all these graphs, you would have this result. So all these graphs, so if you only look at a before-after analysis, you miss these other details, because here you would think, whoa, this intervention really made a difference, isn't it? But in actual fact, there's more to it. So a more detailed analysis often helps, and kind of looking at trends over time is more important. Okay, I'm wrapping up with a few final practical tips. One of the things that's very important is that, at the end of the road, the laboratories provide tests, but you need to be able to give the result to the client, and the clinician needs to be able to work with the client to make changes based on the lab results. With clients with an undetectable viral load, they should be enrolled into less intensive models. Clients with persistent higher viral loads should have a follow-up example and change the regimen. And so there, to evaluate those pieces, you're going to have to work with clinicians and recipients of care. You're going to have to get out of the lab. The other thing is that, as Robert demonstrated, there's frameworks, there's a number of indicators. You as laboratory people have a lot of data available, and you can use quantitative approaches to analyze it. You should use that information as a basis for your evaluation. But what you really should do is add qualitative approaches to it to say, why have these indicators changed? And that's more often to look at in the data. For that, you will have to do key informant interviews or surveys or do some other approaches to get to that question, why has it changed? And well, my last recommendation or tip is really, and if you only take one thing away from my presentation, I'd be very happy if tonight or this afternoon, when you have a bit of time, you go to the website of Better Evaluation, have a look around, learn a bit and pick up some ideas. I'd be very happy. Thank you very much for your time, and I'm happy to answer any questions or any other comments you may have.
Thank you, Joris, and thank you, Robert, for the presentation. We have about 15 or so minutes that we can pick a few questions. I've seen a few questions coming in the chat box, and I'll probably pick the first one that was directed to Robert. And the question is that we have seen that various databases are collected at different points along the care cascade. For most of the countries that have strengthened HIV VL M&E, how is this data managed? Are there national HMIS system able to capture and report all that data, or countries have developed and implemented custom electronic system for managing HIV VL M&E data? Robert.
Thank you for that good question. So I think it's a mix of both depending on the program. So some countries have used their national HMIS system. They have created dashboards where people can look at data in real time, and they're able to look at all of the major indicators that they would like to look at. In other places, the HMIS system may not be set up to do that. So they may have developed their own systems to be able to manage and monitor their viral load data. One of the advantages of doing this through the national HMIS system is that all the data collection is standardized across all sites. So you can do it on an ongoing basis, and the data that's collected every year will be similar. One of the disadvantages of doing it through a national system is that it's typically kind of it's aggregating all of the data together, looking at it in a cross-sectional way, so kind of at one point in time. If you think about the viral load cascade that I showed, that's kind of following an individual patient over time through the treatment algorithm. So some places have developed their own systems to be able to look at the data following patients through the algorithm. And that's kind of one reason why people have looked at separate ways to evaluate their program. WHO actually published in 2019 a toolkit for managing HIV program data. And I'll share the link to that in the chat because this talks more in depth about this question as well. Thank you.
Thank you, Robert, for that. And probably I could have a question of my own on this one. And what we have so far seen is data availability, especially for the second cascade that look at those patients who are not virus suppressed, continue remaining a gap at national level. I don't know whether you have any recommendation to the countries on how they can, what they can do to improve availability of that data for the second cascade.
Yeah, that's it's definitely more complicated to keep track of those patients since they are going through the algorithm and they're going through more steps in the algorithm. So the enhanced adherence counseling, the repeat viral load, whether or not their treatment needs to be switched after the second viral load. So I think that's why some programs have come up with a separate patient register, like the example that I had shown, to keep track of those patients, and then they would need a separate data collection and monitoring tool to be able to look at those patients as well. But in some way, those patients are a big priority because the majority of patients should be virally suppressed, and it's those patients that we really want to find to be able to make sure that they can become virally suppressed either through adherence counseling or through switching their regimen. So even though it's more complex process to keep track of those patients, in some ways those are those are a very important group of patients to be able to monitor to make sure that the program is effectively meeting their needs.
Thank you. And to Joris, and this question comes from Collins, and Collins is asking, for the causative effect, I guess you need to employ statistical tests to confirm effect of intervention. You want to expand more on that?
Yeah, sure. I just wanted to follow on what Robert said. I think I agree that it's very important to follow on patients who are not doing well. In evaluation, you could actually take a sample. So, it's hard to follow all patients all the time, but if you take a sample and look at a smaller group of patients who are not doing well, then you could go a bit more in depth and, look at, why it's not happening or what's happening, specifically, and your data collection could focus, and be of a bit better quality. To come back to the statistical tests, obviously, but I think, that's just one part of, causation, looking at, quantitative tests and looking at statistical tests. If the difference is large, then you don't need any statistical tests. I always compare it, there's nobody who's ever done a randomized controlled trial to see if a parachute would, help you if you fall out of a plane. But if the differences are smaller, then definitely statistical tests will help. The other thing is, I think that there's, and the Better Evaluation website gives those ideas. There's many other ways, to corroborate causation. It's maybe not so rigorous and not so strong as statistical tests, but there are a number of other ways to build a story or to build, what's really happened based on a combination of quantitative and qualitative data that can strongly support causation or can say, yes, this project actually contributed towards these changes, even if it's not, statistically significant. But if you can, definitely it'll help, having, a statistical significant test to show. But that often then comes with randomized controlled trials where you have a good control group. So it all boils down to the resources as well, and how important the question is for you.
Thank you. Dr. Pascal is asking, and this question, she's asking, who are the expertise you need to make the right interpretation of the results at a country level, and how regularly should these studies happen?
It all depends a bit on, how regularly should these studies happen. Traditionally what we do is, if all goes well, we do a baseline, a midterm, and an end-line evaluation. That would be for a regular project. But I think viral load programming is ongoing. So maybe a yearly, in-depth look or a yearly stepping back and having a look at it would be reasonable or fair. Who are the experts? I think, and we forget that, but I think the people who work in the laboratory, the clinicians, and even the expert clients, they are the experts, and they, will probably be, contributing towards better understanding the results, the interpretation, and, where it's going. I think for methodological guidance, or rigor, or helping people setting up the evaluation, you may want to, look at people who are more experienced with evaluation. But I think we, even as evaluators, when we see results, we would want to go and ask people, what does that mean for you in your program? And so it's much more of a collaborative process. And I would, say, yeah, the experts are the people at the coalface who doing the laboratory work and who are the clinicians who see patients. And, you know, they often don't realize it, but it's a matter of helping them take a step back because they're very close to their work. It's difficult for them to see, isn't it? So I think a combination of, you know, people with experience in evaluation and in methodology with people who actually do the work and maybe give you the best interpretation, or and again, it helps also with moving forward in terms of changes or action.
Thank you, Joris, for that. I probably just to link up on the question on how regular this need to happen. I know many countries currently implement the population HIV impact assessment that are done, I think, every 5 or so years. We also have countries that are doing demographic household survey and other population-based survey. I don't know what your guidance would be to country teams on how best they can lead on this kind of population-based surveys.
Yeah, that's a good one. And I think, you know, often, as you say, these are much more expensive and they're population-based. But definitely, if you have specific questions that are more difficult for you to answer based on the data you have or based on a smaller evaluation, if you can approach, you know, the teams who implement these demographic and health surveys and say, this is an additional question, would you want to consider it? That would definitely be very powerful. I like that idea a lot, Michael.
Thank you. Dr. Pascal is asking, and this goes to communicating to decision makers so that they can make, you can use that as a tool for advocacy. And she's asking, from your experience, how should the study team package the results?
Yeah. I think by writing a good, a good executive summary, I think we evaluators write reports that are 20, 30, or God help you, longer pages, but not a lot of people have time to read that, isn't it? I think a good executive summary is okay, but I think even better is to engage in a presentation and have a discussion with the key stakeholders, which could be ministry people, the decision makers, or project people. I think that's much more valuable than p-values or statistical tests. It's there needs to be evidence, obviously, but it can be quantitative and qualitative. But in the end, what you need is an engagement with the decision makers and the key stakeholders, either through a document that's short, 1 page or 2 pages, the kind of key findings, the conclusions and recommendations, and then go in discussion or as an evaluator, facilitate the discussion among the key stakeholders or the decision makers.
Thank you, Robert. We can take one final question, and it's coming from Collins. And Collins is asking, apart from budget consideration, what would influence the decision to conduct an external evaluation first? So, external for self-evaluation, yes.
Yeah, external versus internal. I think often the donors would require or request an external evaluation. I think it depends a bit. I would, even with an external evaluation, it's important that the internal people are involved and have a say, and that it's a collaborative process rather than, either internal or external. What I think would help, and I think, internal evaluations are incredibly valuable, provided you can take that step back in a way. But also I think it would be helpful that when you do an internal evaluation, that you get some counseling or some guidance or some advice from, on methodology from, an evaluator, somebody who has experience in evaluations. I think that would be important. I don't know if that answers the question.
Yes, that does. That answers the question. And thank you so much, Joris. Thank you so much, Robert. Thank you so much, team, for participating in this session. I just want to, we have about a minute or two, and I'm going to split that time between you, Joris and Robert, to make any closing remark and comment that you would want to make. Please go ahead, starting with Robert, then Joris.
Great. Thank you, Michael, and thank you everyone for attending the session today. I guess I would just close by saying that this framework is set up to be as helpful for programs as possible. So we don't provide any specific requirements on, who needs to do this or how often it needs to be done. We just want to make sure that it'll be helpful for your program in general. And I think when you look at an evaluation in that light, how can we best improve our program? Hopefully that makes the process smoother and easier to implement. Thank you.
Thank you.
Yes, yeah, Michael, I want to just, second that. And I want to say, don't be shy, take a step back and, reflect a bit, think about, how you could evaluate internally. Doesn't have to be a big thing necessarily. And then my other piece of advice would be, you know what I'm going to say, have a look at the better evaluation. Okay, thanks a lot.
Thank you so much. Thank you so much, Robert. Thank you so much, Joris, for a great presentation. Thank you so much, team. From us, look forward for the upcoming echo sessions. From us is goodbye, good morning, good evening, good afternoon, everyone. Kwaheri, bye.
Okay, thanks.